All right. Well, welcome. This Best Cares has been the most asked for topic since we started Best Cares. And we are just so grateful that Dr. Bell is presenting today. I'm personally in perimenopause and I'm going to talk about it. And this topic needs to be less taboo and more normalized. I'm excited for today personally and to be able to have Dr. Bell here. Please place any questions that you have in the chat box and we'll try to get to them at the end. I'm just going to introduce Dr. Bell and let her take it away. Dr. Bell is a Yale University graduate with a degree in psychology, earned her medical degree from UT, that's University of Texas, I'm assuming, Health Science Center in Houston, and completed residency training in Cincinnati and New York. She moved here in July 2022 with her two children to join Memphis Women's Consultants for BMG. And she's very passionate about high-risk obstetrics, gynecologic surgery, women's health education, reducing health disparities, and providing culturally sensitive care. So without further ado, here is Dr. Bell. Thank you.
Wonderful. Thank you. Thank you for having me. I know this is a topic that's on a lot of ladies' minds. It can be very difficult to both understand exactly what these two conditions mean, how they feel, and then what can we treat out of how they change our bodies. So I'm going to switch over to showing our slideshow. There we go. All right, so menopause and perimenopause. We're going to go through the symptoms, both common and uncommon, as well as a brief overview of the available treatments. So adult females, women, I'm going to use the term women as well as female throughout this slide deck. That means people that were born with a uterus and ovaries. Or women or people that are born with ovaries in general. So women spend about 40% of their adult lives in menopause on average. 75% of those women are symptomatic, and a third of those experience severe symptoms, which can be lifelong and affect quality of life. So what exactly is menopause? Menopause is the permanent absence of menstrual periods, diagnosed after at least 12 months with no menstrual cycle. This is unrelated to pregnancy or other underlying medical conditions. I put that to state that sometimes patients have a condition like polycystic ovarian syndrome or pregnancy and lactation that are temporary but can last 12 months or more with amenorrhea or absence of periods, but this is not menopause. The same thing applies to women who have had a surgical removal of the uterus but retain their ovaries before they stop having natural menstrual cycles. Perimenopause is characterized by the symptoms of menopause contributed by low estrogen, while a woman or female is still having menstrual bleeding. So it's the evil stepchild where you still have all the feelings, but you still have all the periods. Why do we even have to experience menopause? We as females are born with all of the eggs in our ovaries that we will ever have. And they start to die off in mass at puberty. And then groups of them die off each month, even when we're pregnant or on birth control. And then we have another kind of mass killing or dying off of our eggs when we get near the end of our fertile years. These eggs also have genetics in them. And because our eggs don't complete separation of our DNA, called meiosis, until they're fertilized, we have to kind of depend on the proteins that hold that DNA together to separate properly. This is the reason why people often talk about age 35 with a decrease in fertility, because the DNA doesn't always separate properly. Some of it may have degraded. And even if they're able to be fertilized, we also have fewer proteins inside of the egg that allow us to correct the DNA that the male contributes through semen. So around age 35 and a larger group of them at 37, and then an even larger group at age 40. And then by the end of it, we end up with 1,000 follicles or eggs or less, at which point we no longer have menstrual cycles. It's important to realize that even though we stop having menstrual cycles, it doesn't mean that all of the follicles or eggs are gone. So that can mean that sometimes women experience I call it a random ovulation within the first few years of menopause. Well, they'll have a scary bleed that only happens once, like a normal menstrual period, complete with cramping and premenstrual symptoms that confuses and frightens them. We still go through and do all of the normal things to check for problems that can lead to ovarian or uterine cancer. But 9 times out of 10, this is a natural, normal phenomenon that doesn't lead to anything. Symptoms of perimenopause or menopause start when we don't have enough eggs of good quality to ovulate regularly, and the normal hormones that are produced from them aren't coming from those eggs anymore. Our brain controls that production of ovaries, the production from the ovaries of eggs and the hormones. So the brain has to increase the signaling to try to stimulate the eggs more with follicle stimulating hormone to try to get us to produce more estrogen. What this can lead to is a fluctuation of our estrogen and progesterone made by the developing eggs, and the follicle stimulating hormone and luteinizing hormone also increase, and they affect other receptors on other parts of our bodies. Our periods can become irregular. They can be a shorter cycle than we're used to, where we're used to having 28 days, for instance, between the first day of one period to the first day of the next. Now it's suddenly 21, or sometimes even less. So a woman can feel like she's having multiple menstrual periods in a month, like a calendar month. She can feel like her cycles aren't lasting as long as normal. She may skip some on the other end of the spectrum, or it could be that she may skip 1 or 2 periods and then the next menstrual cycle is heavy and prolonged because the lining has been building up without progesterone to keep it in check. So now let's go into more of what those symptoms feel like from all of the other receptors outside of the ovaries. So these are the most common symptoms that people report. And this is an example from a 2016 survey of 30,000 women aged 45 and up. Hot flashes and night sweats are obviously the most common. That's what everyone's used to seeing. The woman sitting there fanning herself, or the woman that has been treated for something and has no hair on her scalp anymore, sitting there producing steam at her child's basketball game. It can also lead to problems with sleeping. I mean, of course, if you're waking up, burning up in a pool of sweat, you're going to have problems being able to sleep. The lack of progesterone can also cause issues with being able to stay asleep, in addition to falling asleep. We already kind of discussed change of flow and frequency of menstrual periods. There can be mood changes, and that can include anxiety or depressive symptoms. It can include easy irritability, the feeling that your partner is breathing a little bit too hard across the dinner table, for instance, or getting upset at things that seem to be minor compared to how your reaction is. You can have weight gain, especially around the midsection, despite no change in your diet or exercise regimen, low energy levels, difficulty with memory or concentration. And then the last few on this list are ones that we don't talk about as often, and we're going to talk about even more in just a moment. So it's said that there are 34 symptoms of menopause and perimenopause. And so for ease of understanding, I've grouped them into our vasomotor / physical symptoms and for everything else in the mind. So on the common vasomotor side, we have hot flashes and night sweats. And hot flashes can feel like you're suddenly in a hot sauna from the chest up. Sometimes it feels like your hands or your feet or where that heat sensation starts, and then it kind of grows and feels like it's your skin getting flushed, like you're getting hot and sweaty, or you're embarrassed, but that's not the problem. This also then causes a sweat, which can then make you feel cold once the hot flash ends. Night sweats, which is excessive sweating during sleep, which can often wake you up. And we talked about the irregular periods. You can have persistent feeling of tiredness and lack of energy, difficulty maintaining your weight or weight gain despite efforts to lose weight, that minnow belly that everyone likes to talk about online. You can also end up with joint pain. So a really common symptom of perimenopause and menopause is frozen shoulder or joint aches, that are sudden and out of proportion to normal wear and tear. So most of us, especially in the medical community, are used to the wear and tear, osteoarthritis pain in our knees and hips, but it can also be on areas that we don't use as often in that same weight-bearing capacity, like our shoulders. So frozen shoulder can look like you can't brush your hair or wash your own hair anymore easily. You have to struggle, or your arm just won't lift above your, above shoulder level. You can end up with muscle aches and tension throughout your body, headaches, kind of like what people get around the time of their menstrual cycle, can be tension headaches or migraines. People can get issues with bloating and constipation or exacerbation of underlying IBS symptoms. People also have a lot of other issues in other areas like heart palpitations, feeling dizziness, hearing ringing in your ears, or having the feeling of skin itching called formication, like you're feeling like little bugs are crawling all over you, which is number 22, pins and needle sensation. You can have changes in the skin in the area near the vulva and the bladder, which can cause urinary incontinence or leakage of urine. It can definitely change your libido. Once the eggs are starting to decrease, your body has a decreased drive to become pregnant or lower sex drive. You can end up with problems falling asleep, staying asleep, waking up too early and being unable to go back to sleep. You can have changes in your oiliness of your skin. You've always had combination of oily skin and suddenly your skin is dry and you have to moisturize differently. You can have hair loss in a female pattern, which is mostly the temples and the crown of the head, as opposed to the front of the hairline like men. You can end up with changes in your nail texture or hair texture where it's more coarse or dry, or your nails are more weak and brittle and prone to breaking. You can end up with dry mouth, increased sensitivity of your gums or tongue. Changes in how you perceive taste of foods can even change, almost like it did when you became pregnant earlier in life. You can end up with more frequent urinary tract infections. It also can lead to, as we talked about, difficulties with losing weight and changes in bone mass. So it increases your risk of osteoporosis with lowering estrogen with normal menopause. You can have an increased feeling of bloating or gas because even the receptors on your intestines don't work the same way they used to. And you can have a change in your breast tissue with tenderness, soreness, or changes in your breast size. Not to mention the issue of the decreasing estrogen affecting collagen in your skin. And you notice that your skin isn't as full in your face, fine lines, wrinkles, what my people in sometimes dermatology affectionately call turkey neck syndrome, where you end up with a little bit of extra skin underneath the neck and toward the décolleté. All of those can happen because of decreasing estrogen and the effect on collagen and throughout your body. We have treatments for those because all of those are essentially effects of estrogen on different receptors and parts of your physical person. And so a lot of times systemic treatments are available for systemic symptoms. The next category, which is psychological or cognitive, we have fewer tools at our discretion as clinicians, but that doesn't mean that these things aren't real, which is why I mentioned them. You can end up with unpredictable shifts in your mood, including irritability, anger, sadness. While some of that may be a change in life circumstance, such as most people that are in this age range between 40s and 50s are going through changes where if they have children in the home, they're growing up, changing work responsibilities, aging parents, work responsibilities. All these things kind of come together to kind of cause us to have an increase in anxiety and depression incidence and severity. We can also have brain fog from the changes in our brain's receptors for estrogen, causing difficulty concentrating, problems remembering things, sometimes trouble finding words. If you have a woman with ADHD, which a lot of women in healthcare are, you can notice an exacerbation of your ADHD symptoms with perimenopause as well. And all of these things, plus the physical changes, can also lead to a change in self-confidence. So as clinicians, we have to remember to ask certain questions to try to figure out which of our patients may be affected by these and who needs our help and is willing to accept it. So the first question I want us to ask is, are you still having menstrual periods? It helps us to determine if a patient needs more than just hormonal therapy? Do they need contraception to worry about? You'd be surprised by how many patients come to me thinking that they are starting menopause early in their 40s, but are actually pregnant. And that's the reason for their absence of normal menstrual periods and mood swings. And then we have to figure out which symptoms are the most important or the most deleterious to someone's quality of life. So are you having more systemic symptoms? Is it more just in the vulva area where you're having frequent urinary tract infections or dryness and pain with intercourse? How long ago was your most recent menstrual period? Do we need to give you contraception? Does the patient still have a uterus? If a uterus is present, the patient needs progesterone, in addition to estrogen, to protect from overgrowth of the lining that can lead to cancer. And then we also need to know the patient's baseline risk factors for their general health that can be affected by starting estrogen or progesterone because of the side effects or the other effects of those particular hormones. And so that can include their cardiovascular risk, for risk of heart attack or lipid panel, risk of stroke, if they have any family or personal history of breast cancer, family or personal history of venous thromboembolism or blood clots in the legs, lungs, or other sites, and then other risks, right? And then what their values or preferences are. Some patients prefer that they don't take any medication if they can avoid it. Some feel that, dealing with these symptoms is just part of life and they don't want anything to interfere. They just kind of want, something like talk therapy to kind of figure out how to navigate those changes. So we kind of have to figure out what's going on, what are other things I need to kind of take into consideration, and what does the patient actually want us to fix or try to treat. So I encourage you to still ask your patients if they're menstruating through age 55. For some reason, I think a lot of us think that at age 35, we magically dry up and roll up the red carpet so that we can't get pregnant anymore, which is not true, or that we magically go into menopause in our 60s, which is also not often true. The average age of menopause is 51, but a standard deviation above and below goes all the way down to the early 40s or to the late 50s. So if a patient is still menstruating, also known as perimenopause, contraception may be needed. If a patient has already had tubal ligation or vasectomy or has an IUD in place or is already using birth control, then they have that handled. Or if they're abstinent, also not a consideration they have to worry about. If a uterus is still present, we'll need to give them a progestin to protect from endometrial hyperplasia or malignancy. If they have low health risks like cardiovascular disease or diabetes, if we don't have those present, we are able to continue oral contraceptive use until age 55 and then switch to hormone replacement at that time. And even if we're using hormone replacement, a progestin can be cycled for a patient that's still having menstrual cycles. Because she's likely producing her own estrogen from the few times that she does, produce eggs for ovulation, but the egg may not actually continue and actually ovulate, so she'll have unopposed estrogen without progesterone. So cycling to allow for shedding of the endometrium that she's making on her own is important. The other option for patients who are menopausal is continuous progestin therapy, where we don't have a scheduled bleed because for lifestyle reasons, no one wants to have a menstrual cycle in their 60s. And then the other option is something like a progesterone-only contraceptive, like Mirena IUD, with estrogen hormone replacement therapy. And as promised, a little bit more discussion about our perimenopausal patients. So it's true now that more women are giving birth in their 40s in the US than teens are for the first time in US history. Granted, it's not a large margin. It's, per the CDC report from 2023, 4.1% of women give birth in their 40s versus 4% in their teens. But births to women over 40 have increased over 193% since 1990. And births to women less than 20 have decreased by 73% in that same time period. So this is just a reminder that we need to talk about contraception if pregnancy is undesired and she doesn't have a permanent plan or surgical plan in place, because pregnancy undesired does not stop magically at age 40. It's more difficult to become pregnant and stay pregnant in one's 40s if you're trying to conceive on purpose, but it's not impossible to become pregnant by accident or on purpose. And there are a lot of emerging assisted reproductive technologies that are available more and more at lower and lower cost to make it more possible for women in their 40s to conceive. Now, per the Menopause Society's 22 position statement, hormone therapy is the most effective treatment for vasomotor symptoms like hot flashes and night sweats, the genital urinary syndrome menopause, more on that in a moment, and it has been shown to prevent bone loss and fracture. Emphasis on the word prevent there because it's not a treatment for osteoporosis, but can prevent the bone loss that leads us there. There are different formulations of systemic hormone replacement therapy that can come singularly, like estrogen only or progestin only, or in combination with both. And that can be transdermal, like patches, creams, foams. A lot of the foams and even what looks like a deodorant bar or stick can be done at a compounding pharmacy. There's inside of the dermis or pellet therapy, which is also compounded at a compounding pharmacy, and therefore oftentimes not covered by insurance. And there's also oral pills. So the patches, pills, creams, and then we'll talk about in a moment for local rings are oftentimes covered to some degree by insurance. The other caveat I have here is beware of testosterone replacement. Estrogen replacement is made to kind of control the symptoms of menopause. Progesterone therapy is made mostly to protect the uterus if it's still in place. There is some argument that it may help with sleep, but generally speaking, the progesterone is there just to protect from cancer. Testosterone also decreases at menopause for the same reasons that the follicles are dying off. However, testosterone isn't as big a contributor to our overall experience in life as females, because we don't depend on that as heavily as part of our menstrual cycle. Testosterone can also, in excess, lead to different kinds of comorbidities like polycystic ovarian syndrome and the things that come along with that, which can include an increase in the lipid panel, so increased cholesterol and triglycerides, and therefore an increased cardiovascular risk, which needs to be taken into account for these patients. It can also lead to excess oiliness of the skin, unwanted hair growth on the face or body, and severe excess can even lead to clitoromegaly or deepening of the voice. And I have seen too many patients recently who have been to a outpatient clinic that's not covered by insurance because they're trying to be holistic, but then they end up with testosterone only hormone replacement therapy, which is not going to help their hot flashes or night sweats or any of the other symptoms. It may increase their energy a little bit or their sex drive, but that's the extent of the help that it will give. And they end up with other issues like increased cholesterol and triglycerides we have to monitor. And with something like pellets that are compounded and usually placed under the skin every 12 weeks, we can run into issues where your body may absorb it too quickly or not enough. Or if testosterone pellet therapy, you can have male level testosterone for up to 2 or 3 or 4 months before it starts to come back down. So beware of testosterone replacement. Now, as far as systemic hormone replacement therapy, there are some absolute contraindications. Unexplained vaginal bleeding. Now, if we know that it's just a hormone issue to where your bleeding is irregular, prolonged, or skipping, that's it's explained vaginal bleeding. Unexplained vaginal bleeding could be someone who's postmenopausal and is having bleeding but hasn't had any kind of tissue diagnosis yet. Liver dysfunction or disease. If a patient has a known hepatic adenoma, if a patient has severe fibrosis or has alcoholic fatty liver disease or severe non-alcoholic fatty liver disease, it's an absolute contraindication because these hormones are processed through the liver and can exacerbate the size or function of a hepatic adenoma. Active or history of deep venous thrombosis or pulmonary embolism. Estrogen in particular is the one responsible for the increase in thromboembolism risk. It's a small absolute increase in the risk, but if you have a personal history, we don't want to exacerbate that. Known blood clotting disorder or thrombophilia. If a patient has active cancer elsewhere and is therefore more likely to get a blood clot in their legs or their lungs, then we have to take that into consideration because estrogen increase will increase that risk of clotting. Untreated or uncontrolled hypertension. Because of that increased overall risk of clotting, although it's a small risk, if you have untreated hypertension, you would therefore have smaller blood vessels, smaller blood vessel diameter, and there's an increased risk of stroke by adding estrogen. History of estrogen-dependent cancer. So if you had an estrogen-dependent cancer of the liver or of ovarian cancer or breast cancer, then you don't want to obviously add fuel to that fire. Known hypersensitivity to hormone therapy. If we know that you're an over responder because we've tried it before, no more hormone therapy. And a personal history of heart disease, stroke, or TIA. If we know that you have a history of congestive heart failure, if you have a history of heart attack or stroke, where a clot has already happened inside of one of the vessels and has therefore caused some tissue to die off or threatened to with TIA, we don't want to increase your clotting risk. Risks with hormone replacement therapy. As I mentioned, the absolute risk increases, but it's still extremely rare, less than 1 in 1,000. People end up with a venous thromboembolism or gallbladder disease. Now, we notice that we don't really see an increased risk for transdermal hormone replacement therapy for blood clotting, and it may be less increased risk of gallbladder disease if we use transdermal rather than oral. Estrogen and progesterone therapy, EPT, the combination, carries a rare increased risk for stroke and breast cancer. Again, rare meaning less than 10 in 10,000 or less than 1 in 1,000. Estrogen and micronized progesterone, or the human version of progesterone, does not increase breast cancer risk for up to 5 years of treatment. So micronized progesterone may be safer progesterone. There's obviously other progestogens such as combination equine estrogen or the estrogen that comes from horse urine. I know, bear with me, but we do process it. Or other kinds of things like medroxyprogesterone or other processed progesterones or synthetic. Absolute risks are reduced no matter what kind of hormone replacement therapy that includes estrogen for all-cause mortality, bone fracture, diabetes, breast cancer for estrogen-only therapy in women younger than 60 years old. I think patients have been tuned to think that they have to stop hormone replacement therapy 10 years after instituting therapy or 10 years into menopause. This comes from the Women's Health Study and a misinterpretation of data. So whenever we have a research study, we are left trying to figure out which things are correlated and which things are causative. And in this case, when we were looking at things, we realized upon reanalysis of the data that women who started hormone replacement therapy 10 years or more into menopause or 10 years or more after their last menstrual cycle tended to have worse outcomes in terms of dementia, in terms of having breast cancer or ERPR positive breast cancer. That's if you're starting it more than 10 years into it. One could argue that these patients, one, are self-selecting for actually living that long, but also that they have underlying conditions to why they would want to suddenly start 10 years into it. Why were you able to sustain these changes in your body for 10 years and now you want to start hormone therapy? There may be other underlying factors that have now made these symptoms seem more exacerbated. So at this time, there is no recommendation on that we have to ever stop hormone replacement therapy. But we don't want to start it for the first time or begin it more than 10 years after menopause has started. Now on to local symptoms. So we have something called the genitourinary syndrome of menopause, GSM. It comes with uro and genital symptoms that can include urinary frequency, urgency, recurrent urinary tract infections, and incontinence, both stress, and urge incontinence. And that's the I leak when I cough, laugh, and sneeze. And I leak because I can't make it to the bathroom quite as fast as my bladder wants me to. You can end up with vaginal irritation, itching of the vulva, burning of the vulva or vagina, dryness, pain with intercourse, or a change in discharge. As the estrogen effect on the tissue down there declines, the squamous cells thin out. When that happens, the skin becomes more fragile, tears happen more easily, which can lead to bleeding or pain with sex, especially if the lubrication from the estrogen or lack of sexual lubricants being used can cause that as well. Patients find that their sensitivity down there changes as well. Things that used to feel good suddenly start to feel painful, or they're highly sensitive to things. They can find that that area begins to itch for no apparent reason. They haven't changed their hygiene, they're still very clean. It's just that the skin is more sensitive and the receptor sensitivity to histamine changes with declining estrogen. You can also have the feeling that you have a urinary tract infection or yeast infection and don't, because things are just irritated and painful down there. So because it's a localized syndrome or localized set of symptoms, there's localized treatments. And we find that localized treatments are effective for this, but systemic treatments are not. And for vaginal estrogen, which is the mainstay of therapy, they're available in creams that have to be applied with an applicator, almost as though it was a BB or yeast cream. Or they have a little tape measure that comes inside of the box. So you kind of line up the little stream of cream with it, and then you apply it with your finger and wash hands. There is a vaginal suppository available, as well as a vaginal ring for estrogen. There are other therapies available. So some women prefer to avoid all excess estrogen use, although the systemic absorption is extremely, extremely low for vaginal estrogen. And in some cases, in concert with their breast doctor, patients who have had breast cancer that's been treated, they can still use localized vaginal estrogen. But for those who prefer to avoid it or need to avoid it for other reasons, there are other therapies that are estrogen-free. One of them is vaginal rejuvenation, which is a laser therapy where a probe that basically emits laser light is used to cause a surface level injury, and the healing process is going to increase the collagen level and thicken that mucosa. There's other treatments, such as treatments for overactive bladder, which can include ditropan or mirvetric, that can actually calm down the bladder activity so that you don't have as much overactive bladder or urge incontinence. There's vaginal moisturizers for discomfort from dryness. And this is like if you're sitting there feeling that things are rubbing together or feel uncomfortable in your underwear when you're sitting at rest or walking around, moving, running. Then there's vaginal lubricants for sex. A moisturizer does not make sex more comfortable in the moment, and a lubricant is not for use in general when you're walking around. It can get very messy. And as far as vaginal lubricants are concerned, there are both water-based, oil-based, and silicone-based lubricants for sex. And so that's a risk benefit in terms of the individual person as to how they feel. So I encourage patients to try them all out and see how they work out for them. The water-based ones tend to evaporate quickly, and the silicone-based ones tend to get a bit sticky or tacky with use. And so some people have actually started using combinations of them or finding one that has both of those things in combination. And there's also the use of edible oils such as olive oil or coconut oil as well for lubrication. And then there's also possible treatment for interstitial cystitis or UTI if they are present, obviously. If you have a urinary tract infection, I'm not going to give you estrogen and tell you to go home and pray on it. I'm going to give you an antibiotic. So let's take a look at the different kinds of treatments that we have available for vaginal symptoms. So those are the vaginal tablets. There's even a DHEA supplement that people tend to lean more towards if a patient has had a history of breast cancer and they're concerned about estrogen use. There's estrogen creams, gel. There's a vaginal ring that you change out once every 3 months that continues to emit estrogen through it. And then there's a SERM, ospemifene oral tab that's supposed to help, but the most effective is estrogen therapy. And then I kind of wanted to kind of go through a bit more of the systemic treatments for the systemic symptoms. So there's hormonal treatments and then there's non-hormonal treatments. So if we're going hormonal, which is the more effective, there's estrogen-only treatment available if the patient does not have a uterus, if they've already had a hysterectomy. And then there's estrogen and progesterone, obviously, if the uterus is still present. I can do the progesterone continuously or keeping the dose the same throughout the month to avoid having menses, especially if the patient is post-menopause or stopped having periods already, as opposed to intermittent dosing, which is 12 days on. So like the first 12 calendar days of the month, they would be on the progesterone, and then they would have a scheduled withdrawal bleed and then start again the next month. And then there's the option of doing it transdermal with a spray, a cream, or a salve, or a patch, or by mouth. Transdermal is favored if gallbladder or cardiovascular risk factors are present in low to moderate range for cardiovascular risk. But it's available either way if a patient is low risk for those issues. So the transdermal patches, for instance, are often covered by insurance, but they're more expensive in general. The pills have been around longer and are less expensive. So for patients who are on Medicare A and B only without a prescription plan, or people that don't have insurance, I oftentimes, if they're safe for it, will start them on oral because that's what they can afford. However, some of the patches are still brand name, and you can go to the website for the manufacturer and try to have them get themselves into the patient assistance program or get a discount card if they need to have the transdermal and need to have therapy. And then lastly, there are selective estrogen receptor modulators. So think, the Veozas and the ospemifene and things like that, that affect different parts of the body's receptors differently. So they'll have a good effect on bone or on, overall hot flashes without really affecting the uterus, for instance. Then there's a set of non-hormonal treatments, the most common of which are medications that were initially intended for anxiety and depression. And that includes paroxetine, which is the one that most of us think of when we think of non-hormonal. Paxil is the brand name for that. But they have a certain dose that's made for hot flashes, which is 7.5 milligrams. Getting that, because it's brand name, is oftentimes expensive. So we can always go to the lowest dose, which is 10 milligrams of the normal Paxil, the paroxetine. And a patient can go with, 7.5 all the way up to 25 milligrams daily for that. But that's not for use when a patient is on tamoxifen, for instance, for breast cancer. There's also Celexa and Lexapro, which is citalopram and escitalopram, 10 to 20 milligrams daily. But notice that sertraline and fluoxetine do not help with vasomotor symptoms. So they're not recommended for treatment of the symptoms of menopause or perimenopause. They're still fine for anxiety and depression. They just don't help with the rest of the symptoms. Then there's selective norepinephrine uptake inhibitors, SNRIs, like venlafaxine and desvenlafaxine, with the dosages as above. Then there is the fezolitinib, which is a NKB antagonist. There's gabapentin, which is often used for neuropathic pain in patients with diabetes. It also acts as a anti-seizure med, and patients sometimes complain of mental slowing or worsening of their brain fog. Clonidine and Lyrica are no longer recommended because of the side effects, which can include withdrawal hypertension or hypotension while on it for clonidine, as well as confusion for Lyrica. And the two above that are in bold are the only ones that are FDA approved to treat vasomotor symptoms. the paroxetine 7.5 milligrams, and the I can never pronounce that, the F one. And then there's a whole list of nutraceuticals or herbal supplements like chasteberry, soy isoflavones, anything in that category. Technically, those are no longer recommended, but it's based on weak evidence. So I explain to patients that they can always try those things if they don't have a history of, breast cancer, but it may not provide the level of relief that they're looking for. And here are the systemic dosings for estrogen therapy. And you can kind of see that, there's a low, mid, and high range dose. I generally start patients on a low dose if they're perimenopausal with a progesterone, and I may start with a mid-range dose, especially if they're a higher BMI and actually menopausal. We only go to the highest dose if required. And in terms of dosing, patients often ask, is there a certain number you're looking for on my estrogen level or progesterone level? And the answer is no. I only check sometimes before starting therapy to basically state if we are in perimenopause or not, to kind of guide if I'm like, okay, all of your levels are still normal. Chances are you may be at the beginning of perimenopause, but maybe something like contraception is better for you because your hormone levels are still within normal range, as opposed to someone who is menopause by hormones, but they haven't had a whole 12 months yet, at which point I can treat them as though they're menopausal with continuous progesterone therapy, for instance. But the actual dosing depends on their symptom relief. A patient could have a estrogen level of 100 and still feel like they're having hot flashes. So the number on the test doesn't tell me what to treat their symptoms do. If they're still having hot flashes, but not having any breast tenderness or breakthrough bleeding, we can go up on their estrogen. But if they're having breast tenderness or breakthrough bleeding and their hot flashes are well controlled, we can go down on a lower dose. And then here are the dosings for continuous or sequential or intermittent progesterone. And I put the little uterus there to remind us, progestins are for the uterus, not for anything else. Mm-hmm. And I just want to draw attention to the levonorgestrel IUD, and we can use that for up to the first 5 years. It's indicated for 8 years for contraception, but it's endometrial protective for 5. Discontinuation. So long-term use of hormone therapy, including for women aged older than 60 years, may be considered in a healthy woman at low risk of cardiovascular disease and breast cancer with persistent vasomotor symptoms, or at elevated risk of fracture, for whom other therapies are not appropriate. Hormone therapy does not need to be routinely discontinued in women aged older than 60 or 65. So if a patient has been doing well and every time you try to turn them down on their therapy or decrease their therapy and they go back to hot flashes, leave them on it if they're low risk. And here are some sources for further reading. For providers, if you're looking at more of the, North American Society, for Menopause Society, or looking at other like little pocket handbooks. This is my favorite, the little Canadian Menopause Society pocket guide is quite nice. Those are other areas to look for reference, and you can always go back and use this to kind of guide your therapy in terms of, how much dosing should I start with? What should I give? Feel free to use these. They're not from me. They're from the Menopause Society. And now I think is a good time to open up for questions.
Well, thank you, Dr. Bell. That was fabulous. I've learned a lot. Do you have time for a few questions?
Sure do.
Okay. The first one is, if someone already has an autoimmune disease that includes several of these symptoms, how do we know which is which? I always feel like I'm spinning the wheel of misfortune trying to figure out what is wrong with me.
I would say the first thing I would do if a patient came to me with a lot of those symptoms, but is in the age range for perimenopause, or even if they're in their 30s and it would be, premature menopause, I still check hormone levels to see if it's like a hormone deficiency situation that's happening. And oftentimes, if a woman is in her 30s, I'll check an anti-Müllerian hormone list. And that basically looks to see how many eggs are in reserve. If that number is higher than 1, I can pretty much be assured it's not perimenopause in your 30s. But if it's lower than the age range would suggest, then I may be concerned that you're going into early menopause, which can happen with autoimmune disease. I also want to check and see what your level of inflammation is with the high sensitive CRP, to see if there's anything else that can contribute to these things, like other medications you may be on. Some medications can cause hot flashes. Some other medications, like birth control pills, can sometimes cause vaginal dryness. And so I would probably try to go down the list to see if we can exclude first. And then if we can for sure say that it's not from the autoimmune disease, then we can go ahead and try therapy. Or if you're low risk for starting therapy, just start you on hormone replacement.
Great, thank you. Next question. If you have been on the mini pill for over 10 years, being on chemo pills for chronic leukemia, and haven't had a cycle in over 10 years, how will you know when to go to the doctor to get labs checked for perimenopause?
If and when you have symptoms. If you haven't had a menstrual period in 10 years because you're on the mini pill, that's likely part of it. It could also be that you had chemotherapy or radiation that has basically stopped your ovarian function. And therefore, you're not really feeling anything different because you're not having a withdrawal because it already happened. You only need to really worry about checking for labs for perimenopause if you're having symptoms. And so if the only symptom is absence of menses, don't worry about it.
Great. Are the over-the-counter menopause stage indicators accurate?
Generally, no. What I mean by that is there's no test even available to physicians that will tell you, within a number of years, how close your periods are to stopping. But generally speaking, in the last 1 to 2 years, your levels of your follicle stimulating hormone will be high enough to detect that you're close. Your hormones may even look like you're in menopause in between periods before you reach the 12-month mark. So you can have a high level of FSH and a low level of estrogen compared to what it should be and still be menstruating. It doesn't tell you if it's going to be over in 2 years or 2 months, but it can tell you if you're close, but that's about as good as it can do.
Great. I think you may have already answered this, that do you recommend the pellet therapy for a woman that has had a total hysterectomy?
I don't like pellet therapy because it's not FDA regulated. It's a compounding pharmacy thing. And then it's almost like an art form trying to figure out how much to give someone. And then it also depends on how well your body absorbs the treatment. And kind of like when I give someone Depo-Provera, it lasts for 3 months. I can't take it back. So if you are an over responder, you have to be miserable for 3 months before I can change your treatment. So I usually recommend that patients start with oral or transdermal first. And once you got into a good rhythm, then feel free to try pellet therapy with the understanding that we may have to tweak things for a few cycles.
Great. I think you may have gone over, can you be too old for hormone replacement, and can HRTs raise your blood pressure?
Yes, HRT can raise your blood pressure. The estrogen component can raise your blood pressure. It can also make you less sensitive to insulin, ironically. So if you have type 2 diabetes, you can require more insulin or other therapies. But let's see, what was the other part of that?
Can you be too old?
You can be too old to start, but we don't have to stop it because of age alone. So basically, the only indications that we need to stop your therapy once you've already started are that you have too high of a cardiovascular risk, or if you develop a cancer that's sensitive to estrogen. In terms of starting it, we don't want to start more than 10 years after menopause has become into play, because you have an increased risk of dementia and an increased risk of breast cancer at that point.
What are your thoughts on HRT? I'm not going to say this right. Troches. My oral compounded troches contain progesterone, estrogen, and testosterone.
Yeah, are those like those suppositories that you put into the vagina? I think they are. If that's the case, I don't have a problem with it, asterisks, right? So it's better in the sense that you can do a more close titration of it. You know, if it's doing too much or too little, you can always switch the dose more quickly with something that you apply daily or weekly compared to every 3 months with the pellets. But I try to get people to be careful with replacing testosterone because it's hard to do it in a way that you'll feel the difference without causing more problems.
Okay. I was diagnosed with, I'm not going to say this either, right? Lichen sclerosis with those symptoms. Okay, thanks. My OBGYN gave me testosterone, say because I'm allergic to steroids. I still get the HRT pellet. I'm over 60. Do you agree with this treatment or can offer something else? And I have a hysterectomy.
Okay. So you're getting the pellet estrogen therapy and you got recommended to start the testosterone. Is it the DHEA? Because if it's the DHEA, then I would say that's on target. If it's just compounded testosterone, it can increase the thickness of the skin down there, but it may not fix the symptoms from the lichen sclerosis. You're better off doing like vaginal estrogen on top of the pellet therapy, because remember, systemic doesn't cover the genital syndrome.
Thank you. What about over-the-counter natural options such as black cohosh, herbal teas? One said, my friend swears by slippery elm for a natural option.
Yep, all of those are, generally speaking, low risk to start, but also low reward. So some people can start with that and it may give them all the relief they need, but it may not be effective enough to continue therapy without starting something different. So if a patient wants to start those things first, I tell her by all means do, but check back in with me in about 3 months to see if you've had the relief that you were looking for or if you want to try something different.
I like this question. Why is it that so many providers seem clueless about peri and menopause? Even my own gynecologist doesn't even want to talk about it with me. She says if I haven't missed a period, I'm not in peri, even though I have a ton of these symptoms.
Oh my gosh. So there's a lot of misinformation, right? So you have to understand that in medical school, like when all doctors go through it, we get about a month on the menstrual cycle and reproduction. That's it. As OBGYNs, obviously we're in it for 4 years, but we're mainly dealing with reproductive age women. We only deal with people that are in menopause in clinic, and that's a portion of our experience, like maybe a half day once a week. So most of us have to go out and try to find the information on our own. And we have to usually be self-motivated by our age or the fact that we have a uterus and we're about to go through it, like me. So I actually went to a symposium that was about period women over 50 this past fall, which is why I'm able to give the talk. But the average OBGYN doesn't have very much information about menopause other than when your period stops, I can give you estrogen, right?
How long, well, I know you don't like the pellets, but how long should you stay on the pellets for HRT?
You can stay on it as long as you'd like to, as long as it's working for you. You can stay on it as long as you like.
Catherine Presley, can we get a break on our annual health blood pressure for on HRT? That's a good point. Let me think on that one. What's the recommendation if you've had a partial hysterectomy in the mid-40s that is having bad hot flashes without high blood pressure nor diabetes?
Okay.
Having a hard time losing weight even with diet and exercise. Okay.
Yeah, I was going to say, if there's no liver or gallbladder disease, I would recommend a systemic therapy. And it depends on your comfort level. I tend to, if no one has risk factors, I tend to start them on oral therapy because it's easier to titrate because there's more available dosages. And it's not as expensive. If we, find the wrong dose, I don't have to have you pay another $100 out of the pocket the next month. So I tend to start with oral therapy. If you've had a hysterectomy, estrogen only, and find the right dose for you. And then we can switch to transdermal for your comfort. So you can only change the patch once a week or twice a week if you choose.
Thank you. We'll take 2 more questions. I know you said beware of testosterone. Wait, okay, hold on. I know you said beware of testosterone, but what if you have none and are only receiving estrogen in patch form? Is there an appropriate time to use it if you are having symptoms of low testosterone?
So generally speaking, for women, the symptoms of low testosterone include decreased energy, muscle loss, and low libido or low sex drive. The muscle loss is something that happens to all of us, regardless, male and female. And people take anabolic testosterone, like extra testosterone, to gain muscle mass. But same thing with men, it comes with a set of problems that come with it. So generally speaking, the only time I recommend replacing testosterone is if the sex drive is low and you're not able to come to a place where you feel comfortable with your sex drive otherwise, right? And then I try to do it in such a way that we go with the minimal amount of dosage that we can, and try to avoid doing it in a way that's long lasting, like pellet therapy. They even do have some combination patches that actually has testosterone called Estratest. So that's an option as well.
I'm fixing to start on estradiol and testosterone. Will this cause breast cancer?
Estrogen and testosterone cause breast cancer.
Estradiol.
So, yeah, it doesn't directly cause breast cancer. It increases the risk of breast cancer. So think of it this way. Everybody makes cancer cells every day. And our body's job for our immune system is to go through and find those and destroy them. If you happen to have formed a breast cancer that is estrogen receptor positive and small, and you're feeding it more estrogen, of course it's going to grow. But the incidence of breast cancer is still less than 1 in 1,000 of people that are on hormone replacement therapy. So less than 0.1%.
Great. Okay. Well, I know I said one more question, but okay, this is going to be the last one because I know you probably have to go see your patients. Can you offset the weight gain when starting a testosterone injection?
Not exactly. Unless you're doing something like if you're trying to gain muscle mass and you're worried about fat loss, so you're actively lifting weights and eating enough protein, taking your creatine and moving around, then you can take testosterone, but it's made to build muscle. It's not made to burn fat. So if you're not doing the weight lifting and all the other things, you're just going to end up more apple-shaped or more midsection and upper arm fat, in addition to having acne and facial hair. So be careful.
And I think some people would love if you could put your practice and your phone number in there. People want to come see you now. So
yeah,
in the chat box. So thank you so much. We really appreciate this. This was full of wonderful information that hopefully people will take with them, and hopefully this will be something that just causes, folks to talk about this. I will be sending this out to everybody that was on the call and those that maybe wanted to reach or wanted to get on, but work maybe did not allow them to. So thank you so much. And our next Best Cares is going to be June 5th. And it's called From A to Zinc, Understanding Vitamins in Your Daily Life. So I will put that link in the chat box. And we'll see you on June 5th. Thank you, everybody.